Good morning, respected professor, teacher, and senior, and my colleague. I am today presenting the presentation on postoperative pancreatic fistula, current concept in prevention, diagnosis, and management. I am Dr. Swasa from the CMC, second year surgery resident. Adjuvant therapy. If there is pancreatic fistula occurs to the patient. Now, definition. Postoperative pancreatic fistula is a leak of pancreatic juice from the pancreatic duct or the anastomosis, leading to pancreatic enzyme-rich fluid accumulating in the abdominal cavity. International Study Group for Pancreatic Surgery to 2016 definition: a drain output of any measurable volume of fluid with an amylase level more than 3 times the upper limit of normal serum amylase activity on or after third postoperative day. Historical evolution of the pancreaticoduodenectomy. In 1898, Alessandro Cordovilla performed the first partial pancreaticoduodenectomy for the pancreatic head CA. The patient did not survive long term. In 1909, Walter Koch performed the first successful two-stage pancreatic duodenectomy, demonstrating that resection of the pancreatic head was feasible. In 1935, Alan O. Whipple standardized the two-stage pancreatic duodenectomy for periampullary tumors, stabilizing the procedure that became widely known as the Whipple operation. In 1940, Alan O. Whipple modified the procedure to the one-stage operation, which becomes the standard approach. From 1946 to 1960, improvement in anesthesia, blood transfusion, antibiotics, and perioperative care, which reduced the operative mortality to the in Whipple's procedure. In 1970 to 98, introduction to the meticulous pancreaticoduodenostomy technique and increasing surgical specialization, improved outcomes. In 1990, centralization of pancreatic surgery to higher volume hepatopancreatic biliary centers significantly reduced morbidity and mortality. In 2000, development of standardized definition and perioperative protocols, including the internal ISGF definition of POPF in 2005 and 2016, the ISGPS updated the POPF definition, replacing a grade A fistula with the term biochemical leak and refining the grading system. Present era, minimal invasive laparoscopic and robotic pancreatic duodenectomy enhanced recovery after surgery protocol. Surgical anatomy. In pancreatic duodenectomy, what matters the most is the pancreatic duct. So this is the pancreatic. This is the main pancreas. This is the main pancreatic duct, and for the main pancreatic duct, the fistula, there is a high chance of fistula if the duct is less than 5 mm or less than 3 mm, less than 3 mm, then there is high chances of pancreatic duodenal fistula. So, physiology relevant to postoperative pancreatic fistula. During the resection of the head of the pancreas, the acinar cells get destructed, and there is ischemia in the acinar cells, which leads to the pancreatic enzymes release, which release protease, and activated protease autodigestion of the tissue occurs, which leads to the erosion and necrosis of clinical systems, which causes clinical relevant postoperative pancreatic fistula. During the erosion, it also activates NF-kB local and causes postoperative pancreatic fistula. When there is ischemia and inflammation, there is leak in capillary permeability at the site. During the procedure, the main arterial supply is for the head of the pancreas gastroduodenal artery, which supplies the right, which supplies the anterior and posterior superior pancreatic-duodenal arteries, and the posterior supply is posterior and uncinate supply is superior. From the superior mesenteric artery, there is inferior pancreatico-duodenal artery divided into anterior and posterior branches, and the lymphatic supply is celiac lymph node. The entire pancreas is supplied by the lymph node, and their lymph node is named in either location of the arteries, celiac lymph node, hepatic lymph node, and pyloric lymph node, and anterior pancreatic-duodenal lymph node, superior mesenteric lymph node, and inferior body and splenic lymph node. Classification: International Group for Pancreatic Surgery. This is the updated 2016 version. In this event, is increased amylase activity event. Previously, there was grade A, which now in 2016 updated version, they have removed the grade A and named as the biochemical leak, and grade B and grade C. Events in classification: increased amylase activity more than 3 times upper limit institutional normal serum value present present in biochemical leak. Grade B, there is also present, and in grade C, biochemical leak is also present. Persisting peripancreatic drainage for more than 3 weeks. In biochemical leaks, there is no persistent pancreatic drainage for 3 weeks. In grade B, it present more than 3 weeks it presents, and in grade C also it presents. Clinically relevant changes in management of postoperative pancreatic fistula. In biochemical leak, we do not have to go under any changes. In grade B, we have to change in also the management, and grade C, we definitely need the management in postoperative pancreatic fistula. Postoperative pancreatic percutaneous or endoscopic specific intervention for collection. In biochemical leak, there is no need for the endoscopic specific intervention. In B and C, we need this intervention. Angiographic procedure for postoperative pancreatic related bleeding. In biochemical leak, we don't need this angiographic procedure. For grade B and C, we need the angiographic procedure. Reoperation for postoperative pancreatic fistula. In biochemical leak, there is no any needed. In grade B, postoperative pancreatic fistula, there is also no needed for reoperation or re-exploration. In grade C, we need the re-exploration. Signs of infection related to postoperative pancreatic fistula. There is no any signs of infections in biochemical leak. In grade B, there is signs of infection present, but without organ failure. In grade C, there is signs of infection related, but with organ failure. Postoperative fistula related organ failure in biochemical leak is no. In grade B, there is also no organ failure, but in grade C, there is organ failure present. Post-operative POPF related death, there is no evidence of biochemical leak related death. In grade B, there is also no death is present, but in the grade C, there is present of death in the patient. ISJPS definition 2005. Postoperative pancreatic fistula grade A. Drain amylase 3 times the upper limit of normal serum value. No clinical relevance. Postoperative grade B. Drain more than 3 weeks. Change in management. In sign of infection, delay in discharge. In POPF, grade C, interventional treatment, reoperation, and death previously in 2005 ISDPS. Now ISDPS 2016, It is biochemical leak, drain amylase more than 3 times the upper limit of the normal serum value, no clinical relevance. POPF grade B, drain more than 3 weeks, change in management, infection but no organ failure, interventional damage, and geographic intervention. POPF grade C, organ failure, reoperation, and death. Risk factor. It is the most evaluating for the patient who can occur the pancreatic fistula. The most important is soft pancreatic texture. The strongest predictor is soft pancreatic lacks fibrosis leading to fragile anastomosis with 3 to 4 times higher risk. Hard fibrotic gland, chronic pancreatitis are protected. In soft pancreatic texture, what happens that if we suture the duct to the mucosa to the our gland, there is chances of anastomosis. There is cut through. There is chances of duct injury, and another is a small pancreatic duct. A small pancreatic duct less than 3 mm. A small duct difficult to anastomosis and roughly doubles the fistula odds. And another is high BMI. High BMI more than 25 associated with fatty pancreas and technically difficult, nearly 2 times higher the postoperative pancreatic fistula risk. And it is generally seen that the male sex have higher incidence in male, nearly 1.5 times higher than compared to the females. In pathology type, non-pancreatic cancer cases like ampullary tumor, intraductal papillary, mucinous neoplasm have higher POPF rates than pancreatic adenocarcinoma. No preoperative diabetes. No preoperative diabetes. Normal pancreas tends to be softer with higher POPF rates. In diabetes patient, the pancreas will get a little bit harder and there is less risk factor for POPF. A smoking history associated with the pancreatic fatty infiltration and delayed healing, which leads to the POPF, and prolonged operative time. The operating time from more than 7 to 8 hours correlate with higher POPF rate. High intraoperative blood loss, excessive blood loss, and transfusion linked to postoperative pancreatic fistula. Anastomosis technique. No consensus on pancreatic gastrostomy versus pancreatic jejunostomy. Tension-free approaches, Blumgart may reduce the risk. Pancreatic duct stenting. External stenting reduced POPF in high-risk glands, 26 versus 42%. Intra-abdominal infection. Culture positive drainage associated with prolonged fistula and progression to grade C. Neoadjuvant therapy may have protective effect through pancreatic fibrosis. Fistula risk score, risk factor and its parameter and given to the point. The gland texture, if there is firm, then it is given to the point 0. If there is soft, then it is given to the 2. Pathology, pancreatic adenocarcinoma or pancreatitis, then it is 0. And ampullary, duodenal, and cystic isolate cell, then it is given 1. And pancreatic duct diameter, if more than 5 mm, then it is given 0. 4 mm, then 1. 3 mm, then 2. 2 mm, then less 2 mm, then 3. And less than 1 mm, it is given 4. Intraoperative blood loss. If there is less than 400 ml, then it is given as 0. If there is 401 to 700 ml, then it is given as 1. And if there is 701 to 1000 ml, then it is given as 2. And more than 1000 ml given, it is as 3. So total 0 to 10 points is for the fistula risk score, and score risk category and approximate clinical related postoperative pancreatic POPF risk. So 0, there is a negligible chance, less than 5% for POPF, and if the score is 1 to 2, then risk category is low, 5 to 10%, and 3 to 6, then intermediate chance of POPF risk, and if the score is highest, 7 to 10, then ultimately high risk for more than 30 to 40% of POPF risk. So clinical application of the fistula risk is low fistula risk score is early drain removal, standard postoperative care. Intermediate for fistula risk score is monitor drain amylase. Consider prolonged drainage, high FRS, intensive monitoring, delayed drain removal, low threshold for CT scan, early intervention if clinical relevant POPF develops. Alternative risk prediction models. Alternative fistula risk developed by William R. Mungrup et al. In 2019. Variable 3 factors. Pancreatic texture, soft is equal to high risk. Pancreatic duct diameter, small duct less than 3, high risk. And BMI, higher BMI, increased risk. Difference from original FRS is remove intraoperative blood loss, less subjective, easier and more reproducible, applicable to both open and minimally invasive pancreatectomy. Limitation does not consider gland pathology. Updated alternative FRS, additional variable are pancreatic texture, duct diameter, BMI, sex, advantage, better discrimination of high-risk patient. Distal pancreatectomy, fistula risk score, specifically developed for distal pancreatectomy, include BMI, pancreatic thickness, pancreatic texture. Purpose, predict stump-related pancreatic fistula. Clinical presentation in this patient usually present between postoperative day 3 to postoperative day 7. They present in persistent or increasing abdominal pain despite on the several analgesic or NSAID. Patient complains of the abdominal pain, fever associated with chills, nausea, and also vomiting, poor oral intake through anti or oral abdominal distension, generalized weakness. Signs, if signs there is persistent tachycardia, fever if there is more than temperature 38 degrees Celsius. On examination, there is abdominal tenderness, generalized tenderness, localized guarding or peritonitis, persistent or increased drain output, cloud or turbid or enzyme-rich drain fluid. Drain finding, high drain output, drain amylase 3 times the upper limit of normal serum amylase after postoperative day 3. Purulent drain fluid if infected. Blood stain drain output may indicate vascular erosion or post-pancreatectomy hemorrhage. Systemic manifestation, there is raised leukocyte count, elevated CRP and procalcitonin level. It leads to the sepsis and also present with septic shock and multi-organ dysfunction, grade C POPF. Imaging for the POPF, ultrasonography, initial assessment of fluid collection, image guidance for the drainage. CCT is the gold standard. It is always for the, if there is peripancreatic fluid collection, intra-abdominal abscess, anastomotic leak, hemorrhage, and in MRI or MRCP in selected patient, demonstrated ductal anatomy and communication with collection. So complication of post-operative pancreatic fistula, there is the complication and its frequency. So the delayed gastric inputting is the 18% is the complication, pancreatic fistula 12%, wound infection is the 7%, intra-abdominal abscess is 6%, cardiac event is 3%, bile leak is 2%, and overall reoperation or laparotomy is 3%. Prevention, pre-operative optimization, correct malnutrition and hypoalbuminemia, optimize glycemic control in diabetic patient, treat if biliary sepsis and cholangitis, improve overall physiological status, careful patient selection and pre-operative risk assessment. Example is fistula risk score, intraoperative strategy, meticulous surgical techniques, gentle handling of pancreatic tissue, adequate blood supplies to the pancreatic stump or anastomosis, tension-free pancreatic jejunostomy or pancreaticogastrostomy (PG), precise ductal mucosa suturing, secure hemostasis, minimize intraoperative blood loss. Choice of reconstruction is pancreaticojejunostomy, most commonly preferred. Pancreatic gastrostomy in selected case. Choice should depend on the surgeon experience. Neither technique has shown clear superiority in preventing postoperative pancreatic fistula. Intraoperative adjunct, somatostatin analog, octreotide versus pastoral in high-risk patient. Reinforcement technique patches evidence remain inconsistent. Postoperative measure, early recognition of high-risk patient, monitor brain amylase on postoperative day 1 and postoperative day 3. Early CT imaging if clinical deterioration occur. ERAS protocol within early internal nutrition. Octreotide versus pacidotype. European studies have shown that the use of octreotide perioperatively leads to a decreased incidence of postoperative pancreatic fistula. North American trials have not confirmed this result. A recent trial from Memorial Sloan Kettering Cancer Center evaluated the efficacy of pacidotype, a somatostatin analog with longer half-life, 11 hours for pacidotype versus 2 hours for octreotide, and broader binding profile. Pacidotype binds to somatostatin receptor subtypes 1, 2, 3, and 5, whereas octreotide binds to only two receptor subtypes 2 and 5. Introducing pancreatic fistula, leak or abscess of grade 3 or higher after pancreatic surgery, both pancreaticoduodenectomy or distal pancreaticotomy. In this trial, pacidotype and treatment significantly lowered the rate of grade 3 or higher postoperative pancreatic fistula. Leak or abscess 9% versus 21%, relative risk is 0.4 and 95% confidence interval. The finding was consistently in patients who underwent pancreaticoduodenectomy or distal pancreatectomy, as well as in patients with dilated duct versus non-dilated pancreatic duct. Follow-up a prospective observational study from Memorial Sloan Kettering Cancer Center confirmed in the clinical trial. Unfortunately, these results have not been reproduced outside the center.
Continue.
So, types of pancreatic jejunostomy are types of pancreatic jejunostomy is ductal mucosa technique, Cartel Warren technique, and modified Heidelberg technique. Ductal mucosa pancreatic jejunostomy, the most common technique. Principle: the main pancreatic duct is anastomosed directly to the jejunal mucosa. The pancreatic parenchyma is then secured to the jejunal seromuscular layer. Advantage: anatomical reconstruction, precise drainage of pancreatic juice, lower incidence of anastomotic stricture, preferred when the pancreatic duct is more than 3 mm. Disadvantage: difficult in a small duct less than 3 mm. Invagination, donking pancreaticojejunostomy. The cut end of the pancreas is invaginated, dunked into the jejunal lumen. The jejunum is sutured around the pancreatic structure. Advantage is easier in a soft pancreas, suitable for very small pancreatic duct, and simpler and quicker. Disadvantage: reach of pancreatic stump ischemia may increase anastomotic narrowing. This is the ductal mucosa stent. This is Blumgard pancreatic jejunostomy. This is the modern technique used in pancreatic jejunostomy anastomosis. Combines ductal mucosa anastomosis with transparent U structure that anchors pancreas to the jejunum. Technique: place transpancreatic U suture, perform ductal mucosa anastomosis, tie U suture to cover all, reinforce the anastomosis. Advantage: reduces tension, better blood supply, lower clinically relevant POPF in many studies, widely adopted in higher volume hepatobiliary pancreatic center. Disadvantage: require experience, slightly longer operative time. Binding pancreaticojejunostomy principle: the jejunum is wrapped around the pancreatic stump and secured with circumferential ligature. Advantage: it provides a watertight seal. Disadvantage: not widely practiced, limited evidence of superiority. This is the figure of the binding pancreaticojejunostomy. Pancreaticojejunostomy versus pancreaticogastrostomy. The pancreaticojejunostomy remains the Achilles heel of the Whipple procedure because of the frequency of the pancreatic fistula. Several studies have reported successful outcome with pancreaticogastrostomy and reduced leak rate compared with pancreaticojejunostomy. But this finding has not been reproducible in several randomized trials, and most surgeons continue to prefer pancreaticojejunostomy. In cases in which the pancreatic duct is not identified, invaginating of the gland into the jejunal stump or pancreaticogastrostomy to be performed. This is the image of pancreatic gastrostomy versus pancreatic jejunal stomy. Management as per grading: biochemical leak, not a true fistula anymore, no clinical consequences, considered a part of natural postoperative course for up to the 3 weeks, no changes in clinical management required, no longer counted as true postoperative fistula. Management: gradual withdrawal of drain over less than 3 weeks, oral nutrition can be maintained. Grade B, clinically relevant, require intervention. POPF requiring change in postoperative management. If there is clinical feature persistent drainage more than 3 weeks, drain repositioning, endoscopic or percutaneous, sign of infection without organ failure. Management changes may include IV antibiotic and somatostatin analog, partial or total parenteral or internal nutrition, percutaneous drainage of fluid collection, delay in hospital discharge or readmission if discharged. Grade C, POPF, the most severe form. POPF requiring reoperation or leading to single or multi-organ failure or mortality. Clinical feature is ICU admission required, total parenteral internal nutrition, worrisome peripancreatic fluid collection, often associated with complication, post-operative mortality possible. Management: ICU support and surgical reintervention. Role of omental patch in anastomosis. Omental patch principle: a pedicled flap of well-vascularized greater omentum is mobilized, position turned around the pancreatic jejunostomy or the gastroduodenal artery stump, act as a biological barrier between the pancreatic anastomosis and major vessels. Role at the pancreatic jejunostomy: reinforces the pancreatic anastomosis, provide the additional vascularized tissue, potentially support healing, separate the PJ from the adjacent vessel, may reduce local inflammation around the anastomosis. Current evidences: no consistent reduction in clinically relevant POPF grade B and C has been demonstrated. Some studies report fewer peripancreatic collection, while others say there are no significant differences. Why protect the GDA stump? In POPF, the pancreatic enzyme leaks from the anastomosis. Enzyme digests the surrounding tissue and arterial wall. The GDA stump is particularly vulnerable because it lies close to the PJ, and this can lead to the pseudoaneurysm formation and post-pancreatic hemorrhage and post-pancreatic hemorrhage PPH. And omental patch function: wraps or interposes vascularized omentum around the GDA stump, physically separates the artery from leaked pancreatic juice, may decrease arterial erosion and delayed hemorrhage. You take a definition: drain amylase more than 3 upper limit on 3 upper limit on post-operative or later. Classification: ISCPTS 2016. Risk factor: prevention, management, and grade A is no longer a fistula, it's a biochemically leak. And references.
Thank you, Dr. Subhas. Wonderful presentation. I think we should congratulate your mentor, Dr. Rohit Weber is there. Dr. Rohit is your mentor. And Dr. Tamrakar, all the team, whoever is there. So congratulations, very well done. He's a second-year resident, and he presented very well regarding the few things, very relevant things regarding the POV here. He mentioned very clearly that first of all, you remember the Kodivela you said, he was an orthopedic surgeon. He was not a general surgeon or nothing to do with the GI traction. He was an orthopedic surgeon, but performed the Whipples surgery. Historically, though the patient died. So he mentioned very clearly there was a definition in 2005. So we stick to some of the definitions. 2005 was a different definition. Now we have shifted to 2016. So we must remember only one definition. Don't hassle with the previous definition because that will confuse you. So as he mentioned very clearly, grade A leak is no longer considered as a leak. It is a biochemical leak, which just for purpose of recording. So what is the prevalence, how it goes on. If it persists for more than 3 weeks, the way it has to be transferred to the next category, maybe B, general. If it's within 3 weeks, it still remains as grade A. And he very clearly demonstrates. You said that in such cases, just gradual withdrawal of the drain tube will make the fistula tract collapse, and that will heal by itself. There's no other thing is needed. In our ward, we have 3 patients with the post-Whipples right now currently. And there are 2 of them had the vascular reconstruction, 1 didn't have the vascular reconstruction. All are doing well, but you must remember these things. So next thing that he said about the lymph node supply, just to remember it, because not to confuse the audience, everything. There are certain regional lymph nodes for the Whipples procedure, for the pancreatic head resection, or whatever periambulatory carcinoma. The group that have to be taken out is along the hepatic artery, that is level 8 lymph node, along the hepatoduodenal ligament, that means in the porta hepatis, along the portal vein, biliary tract, or the hepatic artery in the porta hepatis, hepatoduodenal ligament, that's level 12 lymph node. The lymph nodes which are located behind the pancreatic head, that's level 13, retropancreatic lymph nodes. Level 14, which are located along the superior mesenteric artery vein, that way it is excised from the root of the aorta, etc. So that's level 14. Along the superior mesenteric vessels. Then there are the lymph nodes along the posterior and inferior border of the pancreas, 17, 18. So these lymph node groups are the lymph nodes that have to be taken out during the Whipples procedure. In general, in the standard practice, there is a concept of the standards, so which we do not take in a home right now. It's not our discussion today. I would like to recommend you while doing the presentation. The last part of the presentation by you was wonderful. In the beginning, the slides were very confusing. So my recommendation to you would be, advice to you, be precise. Don't read out throughout the slides like you mentioned about the ICPS classification of UTM. Don't mention everything. What is how it has to be. There were 7 points that you went through the slides. Just mention the few things. Just in common and define it clearly rather than repeating in each slide. Present, absent, yes, no. For example, in the last slide, you mentioned about the organ failure. In the grade A, there's no organ failure. In the grade B, there may be one organ failure. In the grade C, yes, there is the organ failure, right? You mentioned that. You don't need to mention everything because it will take quite a long time. That will be not impressive for the audience. This is my just advice. But though you have done very beautifully. Very important thing you said is that sometimes we avoid the placement of the drain at all. You said something only, but you didn't go into detail. So you said about the post-operative pancreatic fistula score. So that it is the formula that we can insert into the computer. No need to remember everything. There is the computerized program. Remember, I can calculate what is the risk score for a particular patient. So let's suppose the risk score is low. Then my first question to you would be, could you always place the drain intraoperatively or not?
Yes,
Question major.
Even if there is a low fistula score, then I will place the
You will place. We also place the drain, but the standard practice says that if there is no necessity of drain placement, then it will just increase the infection rate. And that may, in the later consequences, may cause the POPF. So it is better not to. There is no difference. The low group, whether to place drain or not to place drain. This is the one point that has been clear. So not in all the Whipples procedure drain has to be placed. You can omit the placement of drain. We place the drain because there's not only the fistula that we are afraid of, but there is some chylous leak or a sciatic leak that may get collected into the abdominal cavity. So we generally see 200-300 ml of discharge may move in the first postoperative period. So from that point of view, we generally insert the drain, but actually theoretically, so we can omit. Now let's suppose you have placed the drain. When could you remove the drain? According to you, whichever, maybe fistula will develop, maybe fistula will not develop, we don't know. Let's say everything is going well. When are you planning to remove the drain? हाम्रो यही छ वार्डमा दुईटा पेशेन्ट, they are both with the drains. When are you planning to remove the drain?
If then first after postoperative day we measures the postoperative serum amylase drain. If there is less than within the normal limit,
We measure. It's not very important to measure the serum amylase. Why do we measure the serum amylase then? तिमीले भनिहाल्यो. What's the importance of serum amylase? Along with the drain amylase, because you in one of the slides you mentioned POPA, postoperative pancreatitis. This may happen when drain amylase, serum amylase may increase because of the fistula. It may increase because of the pancreatitis. We often insert bacillus cell injury, so we insert the stent inside that may cause the pancreatitis also. That is one of the factors. But fistula, it will also lead to the increment in the serum and the drain amylase. Drain amylase. So we are talking about the drain amylase. Postoperative day 1 ma कति लेभल हुन सक्छ ड्रेन एमाइलेज को जस्ट भएपछि हामी अर्ली ड्रेन रिमुभल गर्न सक्छौँ गर्दै केही छ त्यस्तो आइडिया? It is said that if in the PO day 1, if the drain amylase is less than 5,000 units, then you can consider the drain removal on the 3rd post-op day. Unless patient doesn't have any other symptoms, the sepsis work here, so that is the early drain removal. Either omit or if you have inserted that 3rd post-op day. Reason only case of again, if you insert the drain for a longer time, it will cause the morbidity, increase morbidity. Now, 3rd post-op day ma त्यो एउटा छ हो. अर्को category के हेर्नुपर्छ, is it necessary to see the change in the level of the drain amylase? First post-operative day ma 5,200 आयो. Then as per rules, statistically देखाएको if it's more than 5,000, don't remove the drain on the 3rd post-op day. But on the 3rd post-op day, it has come down to 100. What you will do now? Would you consider for early removal or you do not consider for the removal? कुरा बुझे क्लियर? के आइडिया?
first postoperative day ma 5,200 आयो.
3rd post-op day ma आयो 100.
100 ml.
Normal limits.
Drastically within the normal limit.
So is it the leak or not leak?
Then the no limit.
No leak. Our definition is ICP 3rd post-op day measure. So in those contexts, you can remove the drain. Okay, त्यसै पनि रिमुभ गर्न मिल्यो. डेफिनिसनमै लिकै छैन त किन गरेर यसको चेन्ज पनि इक्वली इम्पोर्टेन्ट छ. कति चेन्ज भयो besides all those criteria that you use. Now one thing that you have not mentioned is the patient develops grade C leak. Our patients एउटा grade B हो, that's not a POPF. This one, he has got the gastric stump leak. That is the grade B because we have not reoperated on him. We have done various things. Southern has done wonderful job taking side of the Southern. That is a great example. That is a great belief. That would be the great C. Great C leak. So what will you do now? Gross sense of the pancreatic jejunectomy. Gross collection that has been recognized not only by the fluid level, drain fluid level, but also by general condition deteriorating, CRP rising, there is fever, tender guarding, CT has to be done, as you mentioned, CT has to be done, or some MRI to see the collection, what is the status intraperitoneal, and you confirm this is the grade C leak. So what will be your strategy now?
Re-exploration.
Grade C requires the re-exploration. Here, now what you will do inside the abdominal cavity?
If there is PJ site leak anastomosis failure, then
नोइसले के गर्छ त्यो पेशेन्ट आयो त्यस्तो ग्रेड सी के गर्छ त्यो
after resuscitation, intraoperatively, if you can see, if you see the basics of the anastomosis, right, then the safest possible side technically is to dismember the anastomosis, exteriorize the pancreatic juice, and
The best answer would be don't dismantle, just put the exteriorize the putting the insert the stent something. Drain widely, put the stent inside, don't do anything with the anastomosis. यदि अब तीन जमै त्यहाँ जेजुराम पनि लिक होला के होला don't do much हैन. Safest, the least minimal invasive that you can do is the exteriorize with some stent and widely drain the local things. That would be best approach. Now you think that's not possible. The next. गर्यो तिम्रो पोसिबल भइरहेको छैन क्या त्यो आइडेन्टिफाई पनि सबै फ्रजाइल टिस्यु छ तिमीले भेटाइरहेको छैन त्यहाँ सधैँ त भेटाउँदैन के गर्छौ
pancreatic crisis. हामीले चाहिँ बेसलाई इन्सुलिनलाई चाहिँ मेन्टेन गर्न राखिरहनु पर्ने fit be considered for curable on single approach.
So एउटा way Dr. Sagarले भनेको एकदम ठिक हो but just a little bit a step previous to that we considered exteriorizing if not possible. Can you consider for binding simply autoligation, somebody autoligation, ligate it, stump totally ligate gare, there will be no duct, there will be no leak. बुझ्यौ कुरो हैन स्टम्प छ सोझै लाइगेट गर्दै सुचर गर्दिन सुचर लाइगेट द स्टम्प ताकि त्यो लिकै नहोस् के इज इट गुड अप्सन can be done but it has to be avoided. It has to be avoided. It can be done यदि तिमीसँग पेशेन्टको त्यस्तो कन्डिसन छ त्यहाँनिर केही नै गर्न नसकिने रहेछ भने there was a survey 30% of the surgeons HPP surgeons said yes. In such circumstances, you have to do it. 70% said you have to avoid it. The majority said were against it. But it is one of the options that has been described in the textbook. The next thing, Dr. Sagarle, that is also a very viable option. If possible, so there are the options. Before that, would you consider Foley anastomosis? Option that is possible. भनेपछि के भने हैन अप्सन त थ्योरेटिकली डिस्कस गरौँ सबैले के गर्छौ has to be avoided single word है किन यसको पनि सर्वे भयो थियो कसैले थर्ड गर्यो कसैले नो गर्यो but it has to be avoided. Can you now thinking next it was the PC it leaked can you transfer to the PC possible option and option also. Yes, it can be done, but it has again to be avoided. The last strategy is what Dr. Sagar said. Nothing is possible than due to the total pancreatectomy. The total pancreatectomy is the morbid procedure. Patient condition pani हेर्नु पर्यो. He will be lifelong gone to the insulin therapy. The option नै केही छैन. The next option only would be the last resort is the total pancreatectomy. कुरा बुझ्यो? So anyway, congratulations, Dr. Subhas. I think Dr. Rohit will be there. And Dr. Tamrakar and also your whole team will enjoy your lecture, will post it, and please convey them your mentors to watch one time. Right? Any question also? Any question?
हर्टिओडीमा फाल्ने पनि त लो रिस्क भएकोलाई नै हो नि जस्तै प्रि अपरेसनमा इन्टरअपरेटिभली लो रिस्क पेसेन्टलाई मात्रै जस्तै हामीले फर्स्ट पिओडीमा 5000 भन्दा कम छ भने वी क्यान टेक द ग्रेड अफ फर्स्ट पिओडी विदाउट इभन मेजरिङ द माइलेज
हैन तर पहिला उले डिफाइन गर्नु पर्यो द पेशेन्ट बिलोङ्स टु लो रिस्क तिमीले इन्ट्राअपरेटिभ डिटरमाइन गर्ने हैन कि प्रि अपरेटिभ डिटरमाइन हैन दैट वाज नट कि इन्ट्राअपरेटिभ डिटरमाइन गर्ने कसरी केयर गर्ने दैट हैज नट बीन प्रुभन हैन त्यो टेक्स्ट बुकमा त्यही भन्छ प्रि अपरेटिभ डिटरमिनेसन पर्छ त्यसको त्यसपछि त्यस्तो आयो भने लो रिस्क ग्रुपमा चाहिँ अर्ली ट्रिटमेन्ट गर्नु क्राइटेरिया त्यही हैन
त्यो पेङ्क्रियाज हार्ट र सफ्ट पनि प्रिअपरेटिभ पनि हो त सर?
मोडिफिकेसन पनि गर्नु पर्दैन है। पेन्क्रियाटिक टेक्सचर मोडिफिकेसन र डक्टर मोडिफिकेसन चाहिँ सरको कन्सेप्ट हो। जस्तै सिरियल डाइजेसन गरेर त्यो डक्टरै एनास्टोमोसिबल गर्नु होइन, एनास्टोमोसिस गरेर के गर्नु एउटा त्यो भयो टकको डायमिटर। जुन चाहिँ नन मोडिफाइबल डिस्ट्राक्टर थियो नि त, जुन चाहिँ हामीले मोडिफाई गर्न नसक्ने भनेर के थियो पेन्क्रियास गर्दा ग्रान्ड टेक्सचर र डकको डायमिटर इन वान आर्टिफिसियल चाहिँ त्यो हो। अनि डकको डायमिटर पनि अलिअलि बढाउन सक्छौँ। दोस्रो भनेको एसपिआरटी गरिन्छ कि नेकमा मात्रै रेडिएसन गर्ने, किनभने पेसेन्टको हेड टु डिटेल्स एक्चुअली हुनु केमोथेरापी गर्ने। केमोथेरापीले डकलाई हार्डेनिङ गराउँछ एउटा त। दोस्रो कुरो ठ्याक्क नेकमा पारेर एसपिआरटी गर्छ कि त्यो सेन्टिमिटर लेन्थ मेजर गरेर त्यही कुरा र तिम्रो त्यसलाई मात्रै रेडिएसन गर्यो भने त्यो नेक पनि हार्ड हुन्छ कि 5 डेजमा चाहिँ 2 to 3 विक अथवा 4 विक्समा गएर अनि देयर इज नो मोडिफाइबल नन मोडिफाइबल डिस्ट्राक्टर पिजे भनेर भन्ने कन्सेप्ट आइसक्यो। दोस्रो कुरा भनेको पेसेन्ट इज भेरी हाई रिस्क। बेसल इन्सुलिन पनि त्यसको भन्नाले पेसेन्ट इज अलरेडी ल्यान्डेड इन्टु डायबिटिज मेलाइटस एन्ड ही हेज हाई रिस्क अफ डेभलपिङ डायबिटिज मेलाइटस टाइम। भन्नाले सिभियर डायबिटिज इन्सुलिन डिपेन्डेन्सीमा आउँछ भनेदेखि मोस्ट सेफेस्ट अप्सन भनेको चाहिँ पेन्क्रियाटिक त्यतिखेर एउटा पेन्क्रियाटिक गर्ने उपल नगरेर आमाले गर्छ। अर्को कुरा कुनै पनि भास्कुलर रिकन्स्ट्रक्सन छ भने त्यसले अस्ति भनेको थियो
कुनै पनि होइन
भास्कुलर रिकन्स्ट्रक्सन
मेजर डबल भास्कुलर आर्टेरियल रिकन्स्ट्रक्सन छ, डबल आर्टेरियल प्लस भेनस छ भने
त्यो भन्दाखेरि कन्सेप्ट अफ पेन्क्रियाटेक्टोमी टोटल पेन्क्रियाटेक्टोमी गरेर यु हेभ जिरो लिक। आई हेभ टोटल पेन्क्रियाट आई हेभ डन विपल जिरो लिक भन्नु त्यसरी पनि कन्सेप्ट लाग्छ।
मेरो सिम्पल क्वेसन चाहिँ टेक्सचर एनालाइसिस चाहिँ प्रिअपरेटिभली गर्ने हो कि इन्टरअपरेटिभ? सिटिएले गर्ने हो कि प्रिअपरेटिभ?
प्रिअपरेटिभ पनि गर्न मिल्छ, पेरिअपरेटिभ पनि गर्न मिल्छ।
सिटी टेक्सचर एनालाइसिसले गर्ने छ
एउटा तिम्रो तिम्रो के मिटर छ ड्युरोमिटर भन्ने हुन्छ एउटा ड्युरोमिटरले त्यसले तिम्रो टेक्सचरलाई मेजर गर्छ फर्मनेस
इफेक्टिभनेस
हजुर
कतिदेखि कतिको लागि फर्म भने कति सफ्ट भन्ने भनेर ड्युरोमिटरले मेजर गर्छ कि त्यहाँ प्रेस गरेर हेर्ने
एक्चुअली अहिलेसम्मको स्केलमा के